So talking about how do we target MET, there have been a variety of approaches that have been tried. So talking about sort of if you think about this as a protein in the cell membrane, there's going to be some of the intracellular part and the extracellular part. The extracellular domains can be targeted by anti-MET antibodies. And I think we talked a little bit about amivantamab. I think that was mentioned as a MET and EGFR targeted antibody. But again, these are usually helpful in the MET amplification overexpression sort of state. For point mutations or exon 14 skipping mutations specifically, we have the selective MET inhibitors, which are truly targeting the overexpression of the protein and the aberrancy, which leads to the cancer. And so here again, I'm going to talk to you about, obviously there's been, as I mentioned, antibodies, and then we are going to talk specifically about the tyrosine kinase inhibitors, which have targeted MET exon 14. So the tyrosine kinase inhibitors are essentially drugs which can inhibit this sort of overactive, over-signaling aspect of the MET, oncogene-driven non-small cell lung cancer. And there's a variety of, names that you can see here, a variety of drugs that have been tested. And you see these Roman numerics right here. This is the different type of MET inhibitors. Essentially, the type 1B, specifically capmatinib and tepotinib, are the two MET TKIs which have been approved for MET exon 14 skipping non-small cell lung cancer. And here in this snippet, I'm showing you some of the data on the efficacy of these TKIs. So for example, for capmatinib, when it is used in the first-line setting, meaning once you have a diagnosis of MET exon 14 skipping non-small cell lung cancer, and if capmatinib is used as a first line of treatment, we have seen responses around 60 to 70%. This is essentially, 60 to 70% of patients that have been enrolled experiencing shrinkage of the tumor or stable disease or partial shrinkage of the tumor in the first-line setting. Similarly, tepotinib in the first-line setting has shown efficacy in the rate of 57 to 60% as well. And then as and when it becomes or is used in the second-line setting, we see that rate drop a little bit, when it's used in the second line. It has also been tested for MET amplification and MET fusion. Again, none of this is currently approved. We're just going to focus on the MET exon 14 skipping part of it. These are the two drugs that are approved by the FDA. There are other drugs on this list which may be approved in other countries such as China. But really, these are the drugs you will hear about when we're talking about MET exon 14 skipping mutation. There are other antibody-drug conjugates, which I think were mentioned, which are again being studied in the overexpression state. And there are a few clinical trials targeting this. But largely right now in our treatment armamentarium, we have these two TKIs. So the management here, I'm showing, the snippet from the national guidelines, the NCCN guidelines. And again, here it is really to hammer home the point that it is really important to use targeted therapy for MET exon 14 skipping mutation, to the point that in the guidelines, you can see on the bottom here that if it is discovered during first-line systemic therapy, it may be recommended to interrupt the current therapy and start capmatinib or tepotinib as the preferred treatment. Obviously, if it is discovered prior to first-line systemic therapy, then the preference is to start capmatinib or tepotinib as first-line therapy. So really important to look for this mutation, and once detected, to target this mutation through one of these TKIs. In terms of safety, so these, again, as I mentioned, these are oral drugs. Capmatinib is given 400 milligram twice daily, and then tepotinib is given 400 milligram once daily with food. And the interesting part of, the safety profile is quite different from, some of the things that we are commonly using, because again, MET exon 14 occurs in about 1 to 2% of non-small cell lung cancer patients. It does have some of the common side effects. So for example, we have the GI disturbances, the increased liver enzymes that we have to monitor once we start a patient on this particular therapy, one of these therapies. Again, we measure the renal function for increased creatinine, but some of the specific side effects that we see with this MET TKI specifically is peripheral edema. This can be asymptomatic, but can, again, depending on the grade, can become symptomatic. We monitor for skin erosions and we consider prophylactic measures. We also consider dose reduction and interruption, as well as diuretics and corticosteroids as needed. ILD has also been seen with these TKIs. It's rare, but again, we are very cautious and monitor our patients for signs of interstitial lung disease, as well as pleural effusion in this particular, therapies.